And welcome to the Dr. Bob Show. We'll spend most of this show talking about common female pelvic disorders. There are lots of those disorders, such as incontinence. We'll be talking about different kinds of incontinence and newer treatment and standard treatment. We'll be talking about pelvic prolapse disease, vaginal prolapse, prolapse of the uterus, prolapse of the rectal area behind the vaginal vault. My guest is Dr. Jeffrey Dell. Dr. Dell has unusual training and one of the first board-certified urogynecologists. So they've combined urology and gynecology and a board for somebody who's specializing in both of those. Dr. Dell will be answering our questions. Hello, I'm Dr. Robert Overholt. I'll be your host for the next 30 minutes on the Dr. Bob Show. Later on, we'll be talking about other medical problems and how those four things we like to talk about: exercise, eating properly, getting proper sleep, and having that laughter in your life. They make us better and healthier people, and we'll be sure that we try and include that in pelvic disorder problems. A lot of information for you. You'll want to stay tuned. We're talking with Dr. Jeffrey Dell, board certified in urogynecology, the director of female pelvic medicine in Knoxville, Tennessee. And Dr. Dell is going to be talking about common female pelvic disorders. Jeffrey, welcome to the Dr. Bob Show.
Thank you. It's great to be back, Dr. Bob.
When we talk about the pelvic floor, in general, what are we describing?
So think about the bony structure of the pelvis, and then inside of that we have a lot of key components and organs. We have the bladder in that area, we have the vagina, the cervix, the uterus, we have the rectum. So very important structures in that area, and the female pelvic floor is the support structure for those key organs. So we have some ligaments, we have uterosacral and cardinal ligaments, we have some connective tissue, fascial planes in the front and back walls of the vagina, but really the most important aspect of the female pelvic floor are really muscle groups. Imagine sort of a bowl-shaped paired group of muscles that form a hammock, if you will, of support for not only the urethra and the bladder base, but the vagina, the cervix, the uterus, and the rectal area. And so when we're talking about female pelvic floor disorders, we're often talking about weakness or defects in those structures that are really related to supporting those key organs.
So there's a homogeneous working of all that together. One thing goes out of place, everything else gets bad, or
you make a great point. The female pelvic floor is a relatively complicated area of anatomy because when you think about the various structures that are all sort of interrelated there anatomically, and it really encompasses a broad spectrum of a female's quality of life. I mean, we're talking about bladder function, we're talking about sexual function, we're talking about bowel function, and you're right, when we have prolapse or weakness in some of the support structures, it very commonly can affect more than one of those areas in the female pelvic floor.
So the things that can cause weakness or cause problems with the musculature there would be age, having babies, obesity,
absolutely,
and just disease processes that
absolutely
go inside?
Those are some of the very common ones. Certainly we know as the aging process happens and we hit the peri and postmenopausal time and we lose those circulating estrogens, then those tissues become thinner, they become weaker. There's no question that pregnancy and childbearing puts a tremendous hit on that pelvic floor. So that's a big key. Other diseases, patients who have chronic pulmonary issues, maybe chronic coughing, patients who have chronic bowel disease, maybe constipation,
yeah,
and they're chronically straining. Patients who are on their feet all day or have very strenuous physical lifting type activities in their jobs All of those things can contribute. Certainly previous surgery, especially hysterectomy, even if it was for bleeding or non-prolapse type issues, certainly sets the patient up for a risk of other types of prolapse or incontinence down the road.
It's really important that you take a good history on what's going on in that patient's life, and then the physical exam to see what's happening in the musculature. I want to jump into incontinence.
Yes.
Talk to me about female incontinence and tell me why it's such a problem.
So I tell you, it's one of the very, very common things that adversely impacts a quality of life for a woman. So leakage of urine when you're not expecting it or when you're not planning for it can be very problematic. Patients do not feel comfortable in their social interactions and their environment. There's several common types of incontinence. Stress incontinence is a very common one. Urge incontinence, mixed incontinence. So just to briefly lay those out, stress incontinence is typically leakage that happens with an event or an activity. Sometimes we say with run, jump, laugh, cough, sneeze, picking something up. There's an event that creates strain or stress, and we have a little leakage of urine that occurs with that. Urge incontinence is a different type of incontinence altogether. Patients may have a sudden but very strong urge to go to the bathroom, but then may not even be able to get to the bathroom in time before that muscle that makes up the bladder begins to spasm or contract, and sort of the dam breaks loose, so to speak, and it's soaking through everything and running down their leg, creating a puddle. Mixed incontinence is a combination of those, and we know that about 50% of patients who present to a center for evaluation of incontinence will have some sort of a mixed picture. It's not always just one or the other. Lots of patients have a little bit of difficulty of both. One final category is that some patients don't properly empty their bladder. They may or may not even know that that's occurring, but if they're walking around with a half or three-quarter full bladder all the time, and so we have retention, then sometimes we'll end up with an overflow incontinence situation where that bladder just finally gets so full and then decides it's going to turn loose and become a real problem for the patient.
Doesn't seem like women have a chance not to have incontinence. Let's talk about what I call the early signs of stress incontinence, where somebody is running or coughing or laughing, anything that causes sudden pushing down against the bladder and the urethra. What do you do for that? How do you treat that person?
So first we do a very careful history, as you said, because there are a lot of different parts of the history and their overall health picture that we want to be aware of. We do a very careful exam on the patient, and we want to look at that pelvic floor anatomy and see if we've got significant weakness. Do we have some prolapse, or are we just dealing with some early mild incontinence issues? Very often we'll do a little bit of specialized bladder testing, but the testing these days is all done in the office setting. The patients drive themselves to the office and back for the testing. There's no sedation or anything involved, but we can gather some very important information about the bladder and the urethra, and we can have them cough with a half-full bladder and see if we observe the leakage. And treatment options for the stress incontinence, unfortunately we don't have good medications for stress incontinence. We have some good medications for mixed and urge incontinence. But if we're catching the patient relatively early on, let's say that in her average day-to-day activities it's not a major issue, but every time she goes running or if she sneezes a couple times in a row, there might be a little leakage. If we catch that patient early on, sometimes with pelvic floor physical therapy, some techniques to strengthen and enhance the support around the vaginal and urethral tissues, we can really see some significant improvement for the patient.
Will physical therapy like that help? If you can teach somebody to, can you teach people to strengthen those muscle Kegel exercises?
You can.
What are those?
Unfortunately, almost every woman has heard from one or more physicians, do your Kegel exercises, and yet it's very challenging for a female to know if she's exercising the right muscle groups in the right way. So we have the benefit of our physical therapy colleagues that we will that are specialized in pelvic floor disorders that we'll sometimes send patients to. There's a variety of newer products that have been developed just in the last couple of years that we can facilitate for the patients through the office to be able to learn how to do that appropriately in their very own home, and some techniques where that data will be stored on their smartphone, and they can, just like a smartwatch, can compare how they're doing today compared to a week ago or a month ago.
And you can see the improvement in the strengthening of the pelvic floor, and therefore that helps prevent the incontinence?
Absolutely. For a lot of patients, that can be the case. If we have a little more significant or severe problem, sometimes it's beyond what we can do by rehabilitating the pelvic floor. And so for some of those patients, we need to think about some surgical procedures in the operating room. The gold standard for stress incontinence is a sling procedure, typically a little outpatient surgical procedure that takes typically less than 30 minutes and has 80 to 90% long-term success rates.
So when I think of a sling, I used to think of a big hammock type sling.
Yes.
You're talking about a little small sling that supports the urethra?
Yes, so think about a tiny little strip of mesh about the size of maybe a 4-inch piece of Scotch tape that we're able to implant in a little 1-inch incision right underneath the urethra, and that sits like a little hammock or a sling of support so that when they cough or sneeze or lift something heavy, it gives us a little backstop of support so that we don't necessarily lose urine.
So there's a lot that we can do to begin the early stages of incontinence. When it gets worse, are there other things that we can do?
Absolutely.
And that's what we're going to be talking about when we come back. What about if your continence is not just that little simple little leakage? And simple leakage is not a good phrase. Any leakage is abnormal. But we'll be talking about if it gets worse, what we can do about it. And then we're going to be talking about prolapse. What is prolapse? And it's very frightening at certain times. We're talking about Dr. Jeffrey Dell, board-certified urogynecologist, and we've been talking about common pelvic disorders, the importance of the integrity of the pelvic floor, and how weakening due to several things can cause disorders. We've talked about incontinence, stress incontinence, and urge incontinence. We've started about where you just have a little bit of leakage, and now we're getting into more difficult problems. So as the stress incontinence gets worse, do you have to be more aggressive in your treatment?
Sometimes we do, and very often the urge incontinence side of the equation may be even more incapacitating for the patient, because a lot of patients with just a liner or a pad, if they have a little squirt of leakage with a cough or a sneeze, can hide that and it not necessarily disrupt their entire day. But with urge incontinence, if that bladder kind of turns loose, so to speak, and the dam breaks loose, and it's soaking through everything and running down their leg, or there's a puddle in the aisle at the grocery store, that's incredibly disruptive for a patient's quality of life. And so very often we have to get a little bit more aggressive. On the urge and mix side of the equation, fortunately, we have a variety of medications these days, and it's kind of the first of all, we work with the patient, we talk about their fluid intake, sometimes with the most basic things of altering the fluid intake, sometimes with some bladder training techniques, some timed voiding, and some pelvic floor physical therapy. Those would be all of the initial kind of entry-level conservative things that we try. But if we're talking about a quality of life that's being severely disruptive and those kinds of things are not helping, then the next level of things would be talking about some bladder medications, which we can get the bladder to kind of calm down and relax. There are many patients that this is really quality of life improving in a major way, but it doesn't work on everybody. And there are patients who continue to have really severe incontinence and those conservative measures don't work. Then we get to what we call the advanced level therapy. And typically there's two main categories for that, at least on the urge and mixed incontinence side. Botox injections in the bladder.
Botox injections?
Absolutely. As you know, that's used all over the body these days.
Yes.
It's used by neurologists for migraines and in the shoulders and neck for torticollis. We've been using it in the bladder for quite a number of years. We're able to do those injections right in the office setting. The patient literally drives herself to our office and gets off the table after a 10-minute procedure and carries on with her day.
So from my thinking about it, the bladder muscles are in spasm and the Botox relaxes that muscle.
That's exactly right. So think about the bladder as simply a bag that's really made of muscle. It's called the detrusor muscle.
Yeah.
And if that's overactive or spasming and causing problems, sometimes by judiciously injecting Botox across the back wall of the bladder, patients can go 6 months or longer at a time from a single injection with improved quality of life.
And that was going to be my next question. How long does the Botox work? So it can last up to 6 months or longer,
in
shorter?
some cases longer. We use a lot of this technology for our patients with multiple sclerosis, and with MS patients we use a little different dosing structure. Some of my MS patients have to come every 3 or 4 months to the office. Others are able to go 6, and in rare cases patients can go longer. But the good news is that it's an office-based procedure. Patients don't have to go to the operating room for this, and they don't have to be put under general anesthesia.
How do you encourage or teach people how to take time to go to the bathroom, to frequently empty the bladder, because that's part of the deal too?
It certainly is. Some patients are always in a rush and maybe they're not emptying all the way. There's a variety of techniques, and sometimes working with the female pelvic floor, teaching them how to properly do Kegel exercises is an important part of this equation, because we know that based on how the nerves of the pelvic floor work, if a woman is feeling a sudden urge to go and she's worried she might not be able to make it in time, if she can be taught to do a well-formed contraction of the pelvic floor, a Kegel exercise, it can actually suppress the nerves that are sending that intense urgency signal and make them calm down or slow down, ease up, if you will, and give her time to make it to the bathroom. So that's just one example of the things that we look for in the patient's history and their typical day-to-day activities, and we look for ways that we can help them figure out how to gain some control.
So there is good treatment, effective treatment for incontinence, both stress and urge and mixed. Let's switch to prolapse disease.
Yes.
When we say prolapse disease in the pelvic floor, what are we talking about?
Well, patients are often very suddenly become aware of something falling out. And this can be very scary for a patient. She might be in the shower and she's bathing and cleaning herself, and all of a sudden she feels that there's something falling out in the space of the vagina.
In the vagina.
Yeah, and this can be a very concerning event for a patient. The good news is almost always it's not serious to their health, but it's quality of life serious to them. And there's a variety of things. The common types of prolapse that we see, if a bladder's falling down, we call that a cystocele. If the back wall of the vagina has become very weak and it allows the rectal wall to push into the vagina, even past the opening, we call that a rectocele. Certainly the uterus can fall down, we call that uterine prolapse. But even if a patient has had a hysterectomy, the top of the vagina, the vaginal vault, can prolapse, and if that continues over time, it can come well out to the outside of the vaginal opening.
It's still attacking from all different sides.
Yes.
Can you tell by physical exam where it's coming from? You have to have special x-rays. How do you determine what's pushing out in prolapse?
Absolutely. So it's a great point. The way we evaluate the pelvic floor for prolapse is using a fairly comprehensive little pelvic floor exam. We call it the pelvic organ prolapse quantification system. We actually will take a series of measurements, about 9 measurements in a very brief and a very gentle pelvic exam, but measurements in centimeters that correlate to the anatomic position or location of the urethra, the bladder base, where the rectal wall is, the top of the vagina, the cervix or uterus if they haven't had a hysterectomy. And we use this quantification system to really gain a very good idea of where is the prolapse located? Do we have several compartments of prolapse, or do we have one primary one?
Is it usually just one, or it's usually
I would say most of the time, because these things are so integrated anatomically, there's usually more than one area that's being affected.
So do you have to do surgery to fix it up? You have to sew the weak areas up and where nothing can prolapse? Or what
well,
do you do?
If we catch a patient very early on, this would be before something's falling all the way to the outside, then sometimes by strengthening the pelvic floor we can really help them. Sometimes even with advanced prolapse, if we're really interested in a non-surgical approach, we can fit patients with something called a pessary. A pessary is a little device. There are many different types in different shapes and sizes. Each one comes in a full range of sizes. So think about a little diaphragm of sorts made out of surgical grade rubber that we can try to tailor and fit to a patient's anatomy so that she can have a non-surgical way of keeping her insides on the inside, so to speak, as opposed to falling out. But very often in advanced cases, we have to think about a surgical reconstruction to put those organs back where they belong.
Now, when you're operating in an area that's already weak, do you strengthen it up when you sew things back up, or does it prolapse right back? What's the long-term care for that?
Well, different types of prolapse require different surgical approaches. So very often these days, if we simply have a cystocele or a rectocele, that is the bladder or the rectum are kind of collapsing into the space of the vagina, very often it's because of some significant weakness in the center of the front and back walls of the vagina, but the patient will often have some good quality, strong tissue on the sides. So in that kind of case, we're able to take them to the operating room. We kind of open up those tissue planes, and by simply putting sutures in, we can bring back the strong tissue from the sides back together in the center and achieve some good results for them. Other types of prolapse, especially if they're very significant, we might have to go in either robotically or laparoscopically or through an incision in the abdomen. We may have to use some mesh in certain types of prolapse to compensate for a complete lack of support.
So it must be really heartwarming to see somebody having such distress and be able to correct that, and not somebody be more active socially, not to be concerned about the clothes that they're wearing and what they're doing and the type of activity. It must be a great feeling.
It is. It's so rewarding to be able to see patients come in who really are in distress because their quality of life is really suffering, and their social interaction is suffering, and their marriage is suffering, and their ability to just do what they want to do and enjoy life on a weekly basis is suffering. And when we're able to take those patients and restore the tissue health and the function, and now they get their quality of life back, it is very rewarding.
Is there anything new in the world of female pelvic disorders that's even going to make things better for ladies?
There's some very exciting new techniques that we're developing these days.
And that's what we're going to be coming back. There are new things that we're developing that even makes it better. I can't wait to hear what these are. I think this has been very instructional to me and very heartwarming because it's such a problem. I want to stay tuned. We're talking with Dr. Jeffrey Dell, board-certified urogynecologist. We've been talking about incontinence, and then we've been talking about prolapse. Excellent discussions. Jeffrey, as I was listening to the discussion, what's the pelvic exam like in patients that are having this many problems?
Well, I think it's important for patients to know that if they're being seen sort of by a subspecialty urogynecologic physician that's trained in evaluating these pelvic floor disorders, it should be a very simple, easy pelvic exam. I tell patients in my office before we move into the exam room, this is going to be one of the easiest, most gentle pelvic exams you've ever had. We're not rough, we're not squeezing or pushing on the tissues. With a very gentle evaluation of where the support defects are, we can gather a tremendous amount of information, but I think patients are routinely amazed at how gentle and simple and easy the process is.
And you told me a story about a person who left saying, if they only knew.
Yeah, very often patients will say, if I knew that it was going to be this simple and this easy, I would have come in years ago.
Fantastic. Now, let's get to some of the newer things that are in the future to make it even better. What's going on?
So there's some really exciting new developments technology-wise that we're now being able to bring into the female pelvic floor to treat a variety of incontinence issues and even mild prolapse. So we're talking about energy platforms, and we're utilizing lasers and radio frequency platforms. Now, this is not...
What is radio frequency, and what type of lasers are we talking about?
So think about this. Patients are familiar. These types of energy platforms have been used for many, many years on the entire face, around the delicate skin of the eyes and the neck, by plastic surgeons and dermatologists for a whole range of cosmetic issues and skin-related issues. So that tells you something about how safe this technology is. It's used on the entire delicate structures of the face, and it's been around for many, many years. What's new is our ability to bring those technologies into the female pelvic floor to treat the vaginal and vulvar tissues. So when we're talking about lasers, we're being able to deliver heat and light to the tissue. Radio frequency is a different type of energy platform that just delivers bulk heat. But when we can bring these types of heating platforms to the vagina, these are treatments that are done in the office setting. The patient doesn't have to go to the operating room. She drives herself to the office and home. There's no needles or IVs or sedation. We're able to do these with topical numbing cream in a very comfortable scenario. There's no downtime. There's no mesh.
So you're using energy platforms And is it the healing of the energy that strengthens the tissue?
So what we accomplish when we deliver this heat or heat with light is that it stimulates a whole cascade of events of the body in response to that heat. So there's new blood flow that comes to the tissue. There's new tiny blood vessels that are developed. We stimulate fibroblasts to lay down new collagen, so we get strengthening of the tissue and thickening of the tissue. We can develop new elasticity. So one of the things that happens to our bodies as we age, particularly in the pelvic floor, is the tissues become thinner, they become drier and less elastic. What these energy platforms do is bring back some of the natural moisture, they improve the suppleness of the tissue, better blood flow, and redevelop some elasticity.
So it sounds like we're working toward being 20 years of age again.
We're working hard at going in that direction.
I think it's just wonderful what you're able to do. Jeffrey Dell, you're a great teacher. I want to thank you for coming to the Dr. Bob Show. It's always a pleasure for me to listen to you teach.
Thank you very much.
Come back and see us again.
Will do.
That's all the time that we have for this show. Remember those 4 things that we want to always talk about? Number 1 is exercise. Not just Kegel exercises, but you need to be out walking or jogging or running or being active. Go to the park. Do anything where you can be active for a regular period of time. It should be 45 minutes and it should be 5, 6, 7 days a week. Get 7.5 hours sleep. Sleep is so important. If you're not sleeping well, discuss with your doctor why. But you simply have to go to bed 7.5 hours before you're going to wake up and hope that that sleep is good sleep. Eat properly, eat more fruits, more fibers. You know how to eat well, eat less as the day goes on. And most of all, what is it we like? Is that laughter in your life. Have a good time laughing, giggle, make life a fun thing, because as it's fun, you'll be healthier.